don't be afraid to say, I don't know. I saw a gastroenterologist with years of experience. And when we got stuck, he said, I don't know what's wrong with you, but if you're willing to work with me, we're going to do all of these tests until we find out. In the meantime, this is how I'm going to help you manage, your issues.
Welcome to the Specialty Café, the podcast that helps you, medical trainees, find your perfect specialty. My name's Cameron Wong, and I'm a current fourth-year medical student at Queen's University. I'm really excited to be producing this episode as a part of the July 1st campaign, a series of episodes that helps incoming residents, like me, prepare to start residency. I just got my draft schedule for my R1 year in internal medicine, so I'm really excited to start, but I'm also really thinking towards how can I best help my patients in the hospital? And who better to ask than allied healthcare workers such as Janet Rodriguez, who is a patient partner. And I'm really looking forward to chatting with Janet today to ask about her role as a patient partner and getting to know what patient partners can do for patients and to help doctors better care for them. So yeah, thanks for joining me today, Janet. I'm really happy to have you here.
Well, I'm very happy to be here, and congratulations.
Oh, thank you very much. Would you be able to introduce yourself and talk a little bit about the many roles that you have?
Well, I personally, I'm a patient. I'm actively in and out of the hospital labs every 2 weeks or at least every month. So I am a patient, but not 24/7. As a patient partner, I took this role when I could no longer work as an interpreter. And I was advised not to stay at home. It will be, depressing. So I joined a few organizations, first as a health mentor with the Center for Advancing Collaborative Healthcare and Education. And that was 16 years ago. And the focus is to share our experience of how, when our healthcare team work in an interprofessional way, that is a benefit to our healthcare. So that is one role, being a health mentor for interprofessional education with undergrad students from a dozen professions from the University of Toronto. But also at my hospital where I receive care, I was the co-chair for the Patient Partner Council, and I did that role for 2 years. Part of that organization also, as a patient partner, I help facilitate sessions for the many students that come to the hospital. It's a teaching hospital. And so there's many students that come and practice. So we do, again, interprofessional education when they are there. I've created curriculum, most recently about disrupting ableism. Another role that patient partners usually have is you're a member of a PFAC, Patient Family Advisory Council. And I've been a member of the PFAC for Ontario Health, for the CEO PFAC group. As I mentioned, my hospital, but also in my family health team. I've been part of a committee. And then again, I've been able to lead a social justice project called Accessibility for All. And that involved training doctors, nurses, all the staff, and the admin staff as well, about disability inclusion, anti-ableism. And that project now has become part of the organization, is part of the structure of the organization.
Wow. Many, many different roles that you have. Yes. And all of these roles sounds like they stemmed from this initial kind of like transition from being ill to wanting to do more for like other patients like yourself. It's very admirable to hear that your experience in coming off of work, but then wanting to do more with your time for others led to all of these different things. It's very admirable for sure.
Well, thank you. I want to make a declaration, if you wish. What I'm sharing here with you, as much as I share with whomever I'm teaching, is the knowledge that I have acquired all this years come also from the community of cross disability, I've learned so much from my peers. And for example, in Toronto, for the last 6 years, we have monthly meetings, which is the GTA Disability Coalition. So these are at least 14 organizations that advocate for different types of disabilities. So that's why we call it as a cross disability organization. And even though I'm not blind or deaf, I've learned from them what inclusion means to them. I have mobility impairments issues. I have mental illness, and I live with chronic pain. So I know this, but I don't know how other people experience different impairments and where are the society barriers when they go seek healthcare. So that was very important for me to have that communal knowledge, because when we did that Accessibility for All project, we were able to do focus group with a community and ask, there were people who had autism, people with mental illness, people with different disabilities with different identities. Some people were deaf, some people were Black, some people were trans, and they were able to share not only their disability, but their disability from the identity that they present with.
I appreciate how forthcoming you are about your own identity, and also that you don't necessarily have the lived experiences of others, but like having learned all these lessons from these different groups, you're able to bring that into your own wealth of knowledge and be able to share it today. And that's exactly what I want to talk most about today, is trying to glean the lessons that you've learned over all these years to try and inform incoming residents like me, and also current residents as well, medical students too, on how we can best serve patients, lessons that doctors would be best informed about when seeing a patient at the bedside, really. So I guess we'll go right ahead into it. Maybe my first question for you to kind of open it up is, what lesson would you say is one that you keep giving to medical trainees throughout their careers about patient care?
One thing is, I am not my diagnosis. So when somebody walks into your space, your clinical space, focus, on something bigger than the diagnosis, than the ailment, than the pathology, because your knowledge of the biology of what's happening may not match with the reality of that particular patient. In my case, for example, if I go to see my doctor and they say, well, in a scale of 1 to 10, where's your pain? And I would say, this morning at home, it was at 4. But because I don't have money for the bus and I had to walk 20 blocks, now my pain is at 9. So what is making me sick? Arthritis or poverty? Right? So then they can take a step back and see Janet in my social location. If they say the best course of action is for you to go see a physiotherapist 3 times a week, excellent. But every 20 minutes of physiotherapy costs $90. Do I have the money for that? And if I don't, and I don't have a good relationship, if I don't have the impression that my clinician is seeing me as a whole, maybe I will say, I'm sorry, I don't have money for that, right? Poverty is invisible. Like pain is invisible. So don't assume, but rather take the time, especially if it is a new patient, a new person you're establishing a relationship with. Take time to see the person in 3D, where they are, what is their social location, do they have supports, can they make ends meet at the end of the month, what is their situation, are they immigrants, can they speak English, can they speak at all, right? So all of these things will help you provide care for myself, right?
It's true. I think medical school focuses a lot on the physical parts of illnesses, the biology behind things, the way medications work, the just like the science strictly. And it was a really big transition for me when I went from my classroom stage of medical school to my clerkship stage of medical school and was treating patients for the first time and realizing that people are complicated. People bring a lot to the clinic or the hospital, and it's like I feel a really big responsibility to understand as much as possible about it, about them, and how I can best treat them. It was a big transition at first, but I do definitely see what you mean, in understanding like what is limiting patients from best receiving care and also participating in their care. What sort of things can I do to make them feel heard, make them feel like they could trust me as well? All really important things. And it was kind of a theme I was getting from what you were just talking about, was to like compassion in healthcare, realizing that like people are not just their diagnoses, but people might have barriers. And like if people don't feel like those barriers are like kind of well recognized, they might feel not open to like receiving care, or like a little bit mistrustful of their doctor. As like, yeah, in like a kind of similar line of thoughts, what are some like important concepts of like trying to engender trust in the doctor-patient relationship?
Thank you so much for that question, because for many communities there's been this distrust, because historically, and probably you have learned this, the medical system has harmed people with disabilities, where, for example, if a child was born with Down syndrome, the best advice that was given to the families was, we're going to take your child and put him in an institution. And that was part of what was going on. So we need to understand that this trust has a foundation. And for some Black people, for example, in the States too, there's been this mistrust. We've all seen it very recently with COVID. So it is important to, first of all, whether you believe it or not, whether you have experienced it or not, to understand that it's real for your patient. So that's the first step. The second step is, if you ask me, for example, for my address, and let's say I live in the streets, I'm going to be embarrassed. I've tried my best to be presentable today. I'm going to be embarrassed to give you my address. It may be a relative's address, so you can send information there and I'll never get it. So rather than asking for my social status, you can introduce the question. It's like, you know what, here in our clinic, we have a lot of information. We work with social workers and we provide supports for people that may need, you know, other things socially. Can I ask a few questions about your situation? Ask about income, ask about housing, because then it's like, oh, you're asking me because maybe you have something that will help me, right? Otherwise, you're asking for what? For your checklist? I don't want to give you that information.
Right, yeah. I can see that like, well, a big part of engendering trust, and from what you said, is like being gentle about what someone's situation might be, and like to like give them control over how they want to shape their narrative. Oftentimes in a really busy clinic or a really busy ward, doctors rely a lot, maybe, and like wrongly so in many instances, on labels. And so just saying this patient is the that patient, they're the that patient. And so I think what you're saying is like is a good wake up call, just to like recognize people are not their labels, like you said before. So really, and that's people are complicated, and but also like in the like doctor patient relationship can be really good to just to give someone control over how they want to introduce themselves and how they want to frame how things have been going on.
Exactly. And it is very important. In my family health team, the St. Michael's Academic Family Health Team, we did this Accessibility for All project. And I mean, I'm so blessed that my family health team is amazing. We have a lawyer, we have income support workers. There's 26 different professions. It's very interprofessional practice. And so they are very aware where are the barriers from the side of providing care. What they did not know is what are the barriers that I face as a patient. So my appointment is for 9 o'clock. It takes me to take Wheel-Trans, which is the accessible transportation. It takes me 2 hours. So if they are delayed, I will be late for my appointment, and they're going to look at me funny, right? In other cases, people may, if the PSW doesn't show up, they may not even be able to get out of bed, and they miss the appointment completely. And then again, they are labeled as no-show, as it's always late, but they don't bother to ask, why? Why are you late? Why are you not showing up? They just give you the eyes, and we notice that. And actually, that attitude, the attitudinal barriers are usually the biggest barrier we have to surmount, and also are very harmful. You know, if you give me a bad attitude, I will never come back, and then you will never know why, because it's too embarrassed for me to say you gave me a bad attitude, right? I respect my clinicians, but how do you navigate that?
Yeah, all because of an assumption, really. Right? Yeah. Just talking about that, it made me really want to ask, as a patient over the past 30 years or so, I'm sure you've been cared for by many different staff physicians, resident physicians, and medical trainees as well, medical students, and maybe even. Uh, what are some of the best ways you felt cared for by all the different medical staff that you've encountered on the road?
I would say when they gave me time to talk about how I felt, right? Not just like, oh, you have 36 inflamed joints, and well, that's a fact for you. And you probably have talked about many patients with arthritis about their joint count. What does that mean to me? Right? So my hands were not working. I couldn't brush my teeth. I couldn't floss. I was afraid, am I going to lose my teeth? So in the back of my mind was not the 36 joints that were inflamed. What are my fears? Will I be able to continue working? And when I no longer could work, what then? What is going to happen? Right? All of these fears are present because my pain is present every day. It's like, here I am. And what else can I not do? And so when they were able to make room for, so how are you feeling lately? Right? And for the longest time, I did not know that I was depressed. I just knew that there was something wrong until finally, as an interpreter, I was in a conference and they say, you will know if you're depressed if, and I was like, oh, that's me. I am depressed. I have depression. I was so elated that finally I knew what was going on. And my family doctor responded. I had the best care for my depression as well. But then when I could no longer work, that fear realized, like, what else is there? Luckily, as I was saying, having the support of a social worker, a clinician, a psychiatrist, my family health team, it's made a difference, you know. But when you see somebody and they go in a scale of 1 to 10, or what joints are paining today, it's like check, check, check. I'm done with the visit and out the door. That is, you're being effective and efficient for your chart and for whatever systems in the hospital or in your clinic. But you don't know about me. You don't know if I leave that room and I may just be crying in the corner for 20 minutes because I don't know what to do with what you have just told me, or I cannot fill out the prescription you just gave me. I took this biologic medication that was $30,000 a year, more than some people's full-time salary. And where is that going to come from? And do I have somebody to support me here? Which, by the way, I don't. My whole family lives in Peru, so I don't have emotional or physical support. And that is important for my clinician to know, for the person that cares for me. And actually, it was very important when my first family doctor was going to retire. He told me 18 months before he actually announced it. He said, I want you to go, and these are his words, looking for a doctor, he said shopping for a doctor in a good way. He said it has to be a young doctor because you're going to grow old with this disease. It's better if you have a steady person. Don't look for a wise person that will retire in 5 years. Look for somebody that you can talk with, that you can discuss, that you can disagree. Somebody that will understand that you have agency over your health and your illness. And I took my time and I did find an amazing family doctor. And of course, my rheumatologist retired. I also did the same thing. I was taught before, so I did the same thing. And I have, I think, the best the best healthcare team ever. So
That's really great to hear.
Yeah.
Yeah, I'm glad that you've come across like such caring healthcare professionals along the road of navigating your diagnosis. Something interesting that I wanted to pluck out from what you mentioned was the elation you felt when someone reviewed the criteria for depression and you felt like you had an answer as to how you were feeling. That's something that reminds me of like a previous episode in where I talked about how um, patients just want control over what their health conditions are.
Yeah.
Oftentimes, a diagnosis can set people free. It can provide people with a way forward. It is also a label, as we talked about, and so it can jail people if used in the wrong context, for sure. But like in the right context and used by the right physician in order to help inform patients, help them feel like they have agency over what they want for their lives, is a powerful thing. Yeah, very, very powerful.
Absolutely. Thank you. But by not using the word empower, I don't like that word. But yes, to reclaim agency. And in that process, just as much as I never I did not know that pain and depression go hand in hand. These are the two main reasons why workers in Ontario stop working and cost a lot of money to the system. But also the fact that as a person with many chronic illnesses, it's up to me to make decisions day to day. I know I need to do physiotherapy, but I also need to eat. Which one should I prioritize? And if I don't have enough, who else can help me among my healthcare team? And it is important to have that agency to be able to have control over, the decisions you're going to make day to day.
Yeah. I'm really, really glad that I got the chance to hear these amazing lessons, life lessons from you having been a patient, also lessons that you've learned from all the people that you've worked with and served, while performing curriculum developments, working in healthcare centers also to educate medical trainees yourself. I think to bring it all back to the one of the purposes of the episode, which is to help inform incoming residents like me and continue to remind other medical trainees what the purpose of being a physician is, which is to serve the patient. I wanted to ask you, what is and also having acknowledged that we've talked about so much that patients are not their diagnoses. Patients are complex, and patients deserve agency and control over the diagnoses. If there is another piece of advice that you think would be really important for a fresh resident to know when they're entering the hospital, a little bit scared because it's the first time that they have signing privileges, they're being trusted as an MD to patients, what would you let them know about caring for patients?
I would say, in no particular order, don't be afraid to say, I don't know. I saw a gastroenterologist with years of experience. And when we got stuck, he said, I don't know what's wrong with you, but if you're willing to work with me, we're going to do all of these tests until we find out. In the meantime, this is how I'm going to help you manage, your issues. I couldn't digest food. That's serious. So the fact that he was honest to say, I don't know, but I'm willing to work with you. It was like, oh my goodness, this doctor's in my corner. So don't be afraid to say, I don't know. And if you don't know, please know that you have a team. They may not be side by side with you. We saw in COVID a lot of teams working remotely. So you have a team of other clinicians, people that you've been to school with, Funny story, my family doctor, my psychiatrist, and my rheumatologist were in school together, and they all retired together. So you have a slew of other professionals in healthcare and, physiotherapists, occupational therapists, SLPs. You have the pharmacists, social workers, psychologists. Everyone can be an assisted, can help you care for this person, this patient. So it's good to know. The third thing, which is something new that we've been doing, is think about social prescriptions. So in a nutshell is, if I don't have food, I need to eat, but I also don't have income. Do you know in the clinic where you are going to be working, or the hospital, wherever you're going to be, where are the food banks around? And preferably food banks that are accessible and not in the basement. Where are, if I, for example, I'm an ethnic person that has a particular culture, or language, or religion, do you know where's the closest Latin American group? If it is an older person, do you know how they can access accessible transportation so they don't try to go outside and fall by taking the bus? So that is not medicine in pills, but it's medicine in the activities that the people can do. In that way, I'm not going to self-medicate, but rather access the services in my community. Believe it or not, doctors and other clinicians carry a lot of power when somebody advised to me, you know what, maybe you should be doing this activity. And that's why when my psychiatrist says, don't stay at home, you should go outside. And I said, okay, I'm going to. And I ended up being a health mentor for the last 16 years. And, your advice carries that intention with which you give it. You want me to be better, so you give me that advice. And if I trust my clinician, I will follow that advice.
That's so important. Very, very important. I think calls back to one of the principles of maybe some types of medicine that's or practices of medicine that emphasize, again, that just the pharmacological treatments of people comes first in a way. And oftentimes I've seen as well, that's the social sides of things, as well as the lifestyle advice of things, gets kind of shunted to the end of the appointment, and it's kind of just an afterthought. But it really, really important to remember that patients are listening, and patients trust doctors a lot to hear what they have to say, because it's their lives. And
yeah, it's the only one I have.
It's true, yeah. That is such good advice, and hopefully all three of those pieces of advice I'll be able to keep in mind when I start residency in just 3 short months. I hope to do all of those things that you said for my patients. It's definitely it's definitely a steep learning curve to become a physician, but I think as you've highlighted along the way through giving all of your advice, doctors are in such a powerful and privileged position to be able to care for patients. And I think I really got excited, honestly, hearing about all the different facets that are important to care for, because it really just reminds me that this is a whole person that I get to be involved in the care of, and really what a joy. So yeah, thank you so much for chatting with me today, Janet.
It's been a pleasure and my privilege to be part of your podcast.
Oh, of course, yes, anytime. Yes, thank you so much for being a part of this special episode for the July 1st campaign, in prepping incoming residents such as myself to become R1s. And I'm really glad that I got the chance to chat with Janet today, and I hope you did as well. If you're a resident or incoming resident, a part of a Royal College affiliated specialty, remember to join, as it is free. And we'll make sure to see you on the next episode. This is Cameron Wong with the Specialty Café. Thanks so much.